much for having me come and speak today. I've got, I see a few familiar faces who heard some of my presentation yesterday. So what I will be doing today is just giving a very brief overview. I think I've got about 15 minutes to give you a sense of what patients are thinking about this notion of an E-integrated care plan. To begin, we set out to do some focus groups, which is a great way to understand the why of the research as opposed to quantifying and saying 20% say this, 20% say that. We don't really get a sense to understand, well, why so few are saying this, or why is there a high level of agreement with a concept like this. So it really allows us to dig down and understand the caveats, if you will, or the rationale behind the views that people are sharing in the sessions. So we set out to do some focus groups. I'll give you a bit of a background on the methodology and the objectives. We covered off a number of areas in these sessions: overall perceptions of the healthcare system, challenges and successes in terms of communications with their care team, an overview of the integrated care plan or plan of care, perceptions on some very specific aspects of a care plan or plan of care, and just some other considerations in terms of willingness to be self-participating in something along those lines, as well as at what stage or when would they expect something like this to roll out. So those are the broad areas we covered off, and what we ended up doing is we went out and we did some focus groups. The people in the groups that we recruited are more like a needle in the haystack, if you will. Generally, when we do focus groups, very broad, we do Gen Pop, if you will, try to get a sense of the Canadian population. Given the topic that we were exploring in these sessions, we were very narrow in how we wanted the participants to kind of compromise what our composite of the participants were. So we really focused in on those who are interacting with multiple caregivers, who have chronic health conditions, who are higher system users. So these aren't the people who are going to their annual physical once a year and that's their level of engagement with their healthcare team. These are people who on a monthly basis, bi-monthly basis, or on a regular basis are interacting with their care team. We also added the caregiver dimension to this as well. So if there weren't people in the session who were having a high level of engagement, these are people who are assisting in the care of a loved one. So they're the ones going to appointments, or the ones keeping track of medications, keeping track of all the different stages, if you will, and all the different moving parts of someone that they're caring for. So that's how we organized the group. So as you can see, we did a number of them. We did 6 of them online and 1 of them in person, and we segmented them by region so that we could try to get a little bit of a regional nuance if there were any throughout the sessions. What I will say overall, by and large, region by region by region, the findings were very consistent. You know, in some cases, particularly when we're talking about health, there can be some very specific regional differences. I would say they were more on a one-off in this instance. Most of the time we were hearing a very consistent story across all the different regions, and as well as between caregivers and patients alike. So what I'd like to do is just very briefly give you the 6 or 7 points, the key takeaways, if you will, of what we learned from doing these sessions. There's more information, there is a more fulsome deck, but these are the highlights, if you will. If you had to walk away with 5 or 6 things, this is what I hope you walk away from when we did this research. First and foremost, what I would say before we get into the support, there are some challenges with communications. Patients are seeing that there isn't really a sense of collaboration and communication between their care team. Now keep in mind, these people are seeing a number of different caregivers. So they do have a sense that there isn't a lot of talking in between their members of their team, or there's some have information and others don't have information, or they're consistently repeating information and the same information to different care members of their team. So with that frame in mind, we went into the E-integrated care plan and talked about what that was, if they were aware of it, and just getting their senses of it. From the outset, what I would say is that support for something along those lines for this kind of tool is quite high. There were very positive comments in terms of, on an initial first glance, what do you think of something along those lines? Very high, very positive. In their view, any sort of tool that can be added to the toolbox that can help some of the communications and help alleviate some of the tensions and pressures that they're feeling as caregivers and as patients is a tool well worth doing. So not the panacea, if you will, on addressing all of the challenges with communications, but a good tool to add to the kit. What I would also say is that there is not a lot of awareness, if at all, I should say, on what an integrated care plan is and what a plan of care is, which may be surprising for some of you who are working with these kinds of documents on a regular basis. But I think it's a language issue. When you're talking to patients, they may understand their medications or what they should be doing next. They don't connect it to that term, plan of care or integrated care plan. So during the sessions, there was a lot of education that had to happen while we were going through and talking about what this document is and what this tool is, to get them to a place where they actually understood what it was. There was a lot of confusion in terms of thinking it was the personal health record that housed every single bit of information in their medical history, which is not the case. To ground participants, what we would do is we would say, imagine you had a knee replacement or you have a chronic health condition. Everything related to that particular health condition would be included in this document. And once they understood that, then it became a little bit more of a reality and a little bit more of a discussion where they could provide some valuable feedback. And again, the feedback was quite positive. They also felt that this was something that can benefit both patients and their caregivers, not just something that is only for caregivers or their care team, I should say, but also something that benefits them as a patient. This was a mutually beneficial thing in terms of sharing information, understanding what is going on with their own health. In a number of cases, we had people say, you go to a physician or you go to the physiotherapist or your pharmacist tells you something, and you're either surprised or you're not internalizing the information, and there's no mechanism for you to go back and refer back to say, you know, what was it that they said? Or what did they say about the dosage? Or how much exercise should I be doing? Or something along those lines. So from a patient and a caregiver perspective, it was something that they could refer back to refresh their memory and just to reevaluate and make sure that the information that they think they heard is in fact correct. They also very strongly had a very strong sense that this is something that they should be able to have access to, something that they should jointly decide with their physician who should have access to. We asked a number of different care team members, if you will, whether or not this person should have access. And the overriding theme, I would say, is they want to participate in that decision-making process as to who should and who should not have access. And it all has to relate back to what is the condition being treated for and who should be involved in that. I'll use the dentist as an example, not to pick on the dentists, but in the sessions, a lot of people were confused as to why a dentist would have access to an integrated care plan. Usually one person would counter that and say, well, you know, if you've just had surgery, you may need antibiotics before you go to a dentist. But just having that clarity and understanding as to how each of the different care team members contribute into the care plan and just being part of that decision-making process. From a patient perspective, and I think I heard a little bit about this in the previous presentation, is the idea of participation and self-empowerment and being more of a partner in your care and being participation and rather than just being the recipient. In virtually all the sessions, many felt that this was something that they could use as a tool, and the term self-empowerment and just patient advocacy. From a caregiving perspective, it was seen as a tool that could also help them just have a little bit more of a complete picture, a little bit more of an understanding of what's going on with the person they're caring for, naturally with the assumption that the access has been granted by that patient for them to have access to this particular document. But seen as a tool that can help provide a little bit more clarity and a little bit more information to them as a patient, and something that they can themselves internalize and act upon on themselves. The last few points I would say is privacy. Generally, invariably, every time we do research when it talks about either EMRs, EHRs, integrated healthcare plans, anything where something is going to be in an electronic format, privacy always comes up. But there has been a shift. We've been doing this work for a few years now, and at the beginning it was don't do it because privacy could be breached. Now the mindset is something to be cognizant of. We need to take that into consideration in the design. We need to factor that in, but it's no longer a reason to not be doing something along these lines. Canadians and in general are we're very online. We're very adept to doing things online. We do our taxes online. We do our banking online. This, for them, is a natural extension, but keeping in mind that the security features and that need to be put in place in order for something along those lines to work. But no longer a reason to not do these kinds of tools. And they're looking to have these tools implemented fairly soon. When we asked, how quickly would they like something along these lines, initially participants would say, well, this should have been done yesterday. There is a sense that there is, how come it's not happening already? Earlier in the discussions, fax machines were berated as an outdated communication tool, and most of them had experience. I got to go to the doctor, get my paper, it's faxed over, I got to take it to the next doctor. So there is an expectation that some of these things are already online, and they should be online. That said, when you ask them if they're going to advocate for something along these lines, it's not something that they're going to be doing a lot of letter writing, a lot of advocacy. They really see that role housing with the physicians. They see it as something that the healthcare professionals, particularly physicians, should be advocating for on their behalf as a patient, not necessarily something that the patient should be advocating for. I would say in Barrie, Ontario was kind of a unique situation where we did have a number of people be very vocal about advocacy. I've done a number of sessions on a number of topics when we ask these kinds of questions, and I would say that the responses are fairly vanilla. Yeah, I might do this, I might do that, but very soft, I would say. And in Barrie, it was different. There was more of a sense that they would advocate for something like this and that they would do letter writing campaigns and that. But not something on the whole, by and large, that patients felt or caregivers felt that they should be advocating for. If anything, they may switch a physician, but they chuckle at that at the sense that they don't feel like that's really an option. There is a sense that there is a shortage of physicians. So not something that they would really take action upon, but it would be nice if something like this were to happen sooner or later. Timeline, I would say about 5 years is their max expectation if it hasn't happened already. So to wrap up, what I would say is that there's a lot of positivity and a lot of receptiveness for patients who are looking for tools like this, and particularly for them from a patient perspective, it provides information, it provides clarity of information, it provides a way for them to understand what's going on with their own health, and it also provides a tool for them to refer back to and be more of a participant in their health, particularly when it comes to chronic health conditions, and from a caregiving perspective, more of an aspect and a way for them to have a little bit more information and be a little bit more informed about the person that they're caring for.
So as Maureen had introduced, we also were engaged to help with the assessment of the current state of e-integrated care plans. And there were really sort of two key questions that guided us. What is happening in this area? Are there any examples of e-integrated care plans? Who's doing them? And what lessons, and the second question was really what lessons can we learn from that? And that really was our kind of guiding posts, guiding questions. In terms of today then, what I want to do is share our key findings on the current state, as well as share key enablers, those lessons to support the planning and implementation of e-integrated care plans. In the afternoon, we're going to after lunch, engage in the remainder of the objectives, which really is to engage you into discussion about you as clinicians, what your needs are around care planning, around e-integrated care plans, and really how can these be aligned with what you've heard around what patients and what the public are saying are their needs, and help also identify what could be some priority next steps. So really about half an hour presentation. We will then break for lunch, come back. We'll actually give you instructions for breakout sessions after lunch, and then enter into small group discussions, and then do some sharing. We have some polling questions that we want to do for checking in as a collective group, what do we think, and then just wrap up. So I think this is going to go, this session, right up to 2:30. Now, to start out with, there was a definition of e-integrated care plans, and you've all seen that definition, and it looks something like this. I'm not going to read all of it, and you've probably seen it already today, I'm not sure, but they were, not yet, okay. But there were three key elements to that definition, and that definition meant that providers would be collaborating and coordinating their plan of care, interdisciplinary or a coordinated plan of care, that they would be continuity of care, not within just an organization, not just within inpatient and outpatient, but also across care settings, primary care, acute care, home care, etc., and that the patient would be part and parcel of not only the contribution to the plan of care, but an ongoing involvement in terms of viewing the plan of care, being able to add to it, to be able to exchange information with providers, etc. So this was a pretty kind of comprehensive, if you will, definition of e-integrated care plan that we were given as a starting point. And this work really came about when this topic area was first identified as a high priority. And then really how all of these three elements of an integrated care plan would support the outcomes of care, not just from the perspective of the patient and family, but also from clinicians and the health system. So this was our starting point of talking about e-integrated care plans with those that we were engaging as part of the environmental scan that we were conducting. So we used a number of different ways of trying to find this information. We reviewed documents that had been produced previously by different organizations that were trying to look at care plans and integrated care plans. We looked at the literature to inform us what the state is. We did internet searches. We also conducted a short survey, which I'm going to share some results. And we interviewed about 17 key informants from a wide range of roles and projects, mostly people who were involved in doing one or the other type of integration of care planning to understand what did they learn as part of their lessons that they encountered and barriers as well, and also where else could they point us to in terms of what other projects or initiatives are underway. So I'm going to share briefly the survey, and I believe all of the people in this room were invited to participate in this survey. There were about 80 people that started the survey, but we didn't have all 80 complete. There were about 80% completion on this survey. What I wanted to point out is that we only had about 10 peer leaders involved in the survey, and there is an opportunity to still participate in the survey. The survey is still open. And so I believe all of you have been asked if you still want to participate, you can still do that. When we asked people about what their primary profession, you can see mostly they were nurses, but also some medicine, pharmacists, and a group who identified themselves as others. Largely, these individuals were people in some type of a support role. We had all 10 provinces represented, none from the north, so that would be a gap here. When we asked what sectors people worked in primarily, you can see primary care and acute care as being heavily represented. In terms of what roles, largely clinicians, as well as those who identified themselves as administrators, managers, leaders, and then a whole bunch of people who were others, again, largely people who are doing project-level work or some type of supportive role in an association, a regulatory body, that kind of thing. Now, we asked people this question. Does your organization have electronic patient care plans? And interestingly enough, of those people who responded to this survey, you can see that a good third of them said that they had electronic integrated or electronic care plans. When there was also a comment section on that question to ask, describe what this means to you. And largely people were referring to things like their EMR, or referring to vendor care plans, or referring to things like flow sheets and templates, et cetera. And then there were a whole bunch of people who didn't really actually describe what they were implementing. When we were also doing the interviews, we found very similar finding to what Megan talked about. There's a lot of confusion about what a care plan is. Some people felt that the decision support tools that they were using were giving them a plan of care, that they were planning care as part of the different information that's available, that's collected in their electronic health records, that they were using best practice guidelines as part of their interventions. But really talking about some clarity around how that definition was, there was a lot of confusion. We did ask also if they didn't have an electronic one, were they using a paper-based one? And again, there are a good group of people responding there. But they said the same kinds of things that others have said already today, that they tend to not be formalized or consistently used or universally used, that they tend to rely on best practice guidelines or ministry guidance. Now, this question was really to try and get the sense of how, does the whole team get involved in contributing to the care plan? And here you can see that we had about 22 people that said they had an electronic care plan, and about 14 say that that all care providers are contributing. So about half of those are really having a kind of interdisciplinary type of care planning, the way that our previous presenters, the Ontario Shores group, were saying that they were all involved as an interdisciplinary team. But when they were involving the team, all the relevant disciplines were involved. However, many did not include physicians. So again, isn't it interesting, a similar finding? In some cases, there were case managers involved in developing a care plan. Others in the team could view it, but weren't really contributing to it. So they may be involved in perhaps case conferencing and so forth, but in terms of actually making changes and so forth, it was limited. The question around, if you have an electronic care plan, how is it integrated with other functionalities? And again, pretty much all of those who said that they were using an electronic care plan said they were integrated with electronic health record. And the kinds of things that they talked about are listed there: allergies, diagnostics, referrals, etc. It's a little bit unclear, really, about this because, as I mentioned before, the whole notion of understanding of a care plan is weak, and so this question is already troublesome. Now here, the question was really about, is the care plan integrated within your organization, so accessible to care providers and so forth? And again, all of those who had said more or less, that they were using care plans, more or less said that they were, but mostly through some type of a viewing feature, that it was available to see them and not necessarily to add to. And then the question was, okay, so if you've got it in your organization, do you now share it across settings? And this is where is the least number of individuals who said that this is actually happening. And when they do share it, it's a similar kind of example that our Ontario Shores people said, that sometimes it's in a viewer or a paper copy or a scanned copy that's uploaded and shared. But this is sort of the least, if you will, developed concept out of the three. In terms of the challenges and barriers that the survey participants identified, and I kind of grouped them into sort of four big categories: big system kinds of issues, such as political uncertainty, working in silos, lack of leadership and funding, the whole issue of complexity and scalability and so forth. All of the kinds of challenges around technology, where there were various examples, including vendor blocks, where vendors aren't able to meet the practice requirements. And then there were a whole bunch of challenges and barriers identified in the category of care plans. And again, the issue of definitions came up, that we're not quite sure, what we all mean when we talk about care plans. It's sometimes too time-consuming to develop standardized care plans. When you do have them, it's difficult to individualize them. And then how do you integrate it with decision support tools? And then there were a few that said we don't use care plans. So both in the survey as well as our interviews, literature, and so forth, we were looking specifically for examples of e-integrated care plans that hit those three concepts: the concepts of interprofessional collaboration, patient involvement and empowerment, and continuity of care across settings. And really, we were having challenges finding very many examples that hit all of them. But we did find there. So my question was, are we there yet in terms of meeting all of those three areas? Probably not. But there were a whole bunch of things that people talked about related to it. And I'm not going to go into each one of this, but just to kind of give you a sense. But we did find a few examples that I'd like to share, and I've kind of bucketed them in these four areas. And I'll speak to each one of these individually. So the first area was really in the context of a lot of concern right now where there are issues of system gaps when patients go from one sector to the other. So transitions and discharge from one service to another seems to be a real preoccupation, and where there are some initiatives underway. So I think, Dr. Fisher, you mentioned the coordinated care plan example with the health links. The health links have developed here in Ontario, have developed a care plan template, which is called the coordinated care plan. And don't let me, yeah, okay, good, thank you. And this is now actually getting adopted across a whole bunch of different regions in Ontario, still on paper format. Eventually, it's going to go into some type of an electronic platform. And the idea is really to help consolidate information and a plan that can be shared from one care setting to the next. And then similar to a coordinated care plan, and these terms we're familiar with, discharge summaries and so forth, but there's now a lot more concerted effort happening in terms of standardizing discharge summaries. Some examples I've listed there. UK has done a tremendous amount of work in this area, and they now have a electronic standardized discharge summary record across the entire country, and their uptake is pretty high at this stage. Some of the other examples we saw really sort of spoke to us in terms of really having that patient empowerment and self-management theme as sort of more central to those care plans. And in the cancer survivorship care plans, so these are care plans developed towards the end of an individual's cancer treatment. These care plans are developed very collaboratively with the patient and family. The patient carries those or has them accessible to them electronically through really the rest of their life, because they could potentially have impacts or influences from their treatment throughout their life. And they are now also standards available for survivorship care plans. There are a whole bunch of different templates available, and this is now also getting adopted in various Canadian institutions as well. Some are available online that patients can just access themselves and develop themselves their own care plans, but by majority of them are linked with an organization, a cancer treatment center that invites patients to be part of using these care plans. Similarly, patient health records and patient portals, there are very, very many of these available, and they're just starting now to have a bit more structure in terms of personal goals and activities or self-management care plans with or without clinician involvement. And so there are many examples around that. You'll see the term MyChart sort of appearing all over the map in many different organizations. Now, these examples that I have on this slide are perhaps the ones that have also been able to, if you will, hit not all three of those concepts equally, but try to really progress on the idea of sharing the care plan and the not only with the patient and family, but across care settings and care providers. So the first example there, the Diagnostic Assessment Program, the Electronic Pathway Solutions. This is developed by Cancer Care Ontario. And it's a tool that's used from the moment the individual has suspicion of cancer and is involved in the cancer journey, ongoing basis. It's across the care settings. Patients have access to it. They can use secure messaging in that tool, and I believe they're also looking at patients being able to do their own goals and so forth. So it's one that has really progressed that example. And similarly, the Cancer Center in Laval has done some similar work, and they have also done it across an entire sort of region, if you will, in Laval, and across different care settings that are connected with the center. The Mosaic Oncology Information Management System is a vendor-based and their treatment protocols, and these are now also being used by different cohorts of organizations in the cancer field, and there are a couple of examples, one in Quebec, one in Ontario, that are using that. There are other projects that have come about, and that probably we haven't heard all of them, but one of the examples that's been around for several years now is in Hamilton, Ontario, where they've taken some of the chronic disease categories of patients and developed an integrated comprehensive care plan project. And these cross between acute care, long-term care, and home care. There's another one in the U.S. Called the Kendall Corporation, and this one is focused really on the aging population. It doesn't include acute care, but includes many of the sort of different continuing care and long-term care types of settings. And then another vendor-based one called Healthy Registries by Cerner, and the intent here is that it will not only help to cross organizations, it's right now in the context of chronic disease management, but it would also have a longitudinal care plan, meaning being able to have a care plan sort of basically for the person's lifespan. Now, we came across a few examples of care planning work that was happening perhaps in a, if you will, in a much larger scale. Alberta has a program that they call the COACT. It's very much at the bench stage, at the planning stage, and it's called the COACT. It has many different components to this. One other component is an integrated plan of care. And the idea here is that it will be, again, with the vision of one patient, one record through the lifespan, and interprofessional patient access and being able to use across the care system. It's very much at a planning stage. Its one big dependency is that they're looking to integrate it with their provincial clinical information system that is also very much at the early stages of development. They have other systems in place right now, but they're trying to get to a provincial model. In Quebec, there is an initiative that actually started at University of Sherbrooke, and it's sort of like your RAI, the resident assessment instrument, but their version of it, and it's again being used to generate care plans, being used across care settings. And similar to that one, there is now a mandated one called RCIPA. And RCIPA is very much based on the QEMC, and I won't go through all the letters for you right now, but it's an inter-RAI type. The RCIPA is a mandated one, meaning that every organization involved in this instance, I believe it's for the older adults, so elder care. The unfortunate part in Quebec, though, is that those two our systems are being implemented in parallel, where the QEMC is a more comprehensive tool, the RCIPA is a more streamlined version, and they have some duplications of work and some barriers and so forth there. And similarly, the Brooklyn Health Information Exchange, this is implemented in 22 states and is focused on severe mental illness. So we are going to talk a little bit about what did we learn in terms of the lessons learned. So I'm going to go through this fairly quickly, but the one thing I want you to make a note is that we are actually going to, in our small group discussions this afternoon, get a lot more discussion around the various enablers. So there's sort of 8 categories that we've identified through, again, mostly through the literature and the interviews with key informants. So one of the first things we learned is that the vision of one patient, one record is really helping kind of galvanize, if you will, the whole area of integration. And it's also helping in the context of patient empowerment, patient engagement, and more patient-centric approaches, and really thinking about the patient as the partner, the driver of their own care, having self-management, empowerment and responsibilities, but also having the patient's ability to view, add, exchange, and communicate wherever they might be in accessible language, mobile access, etc. So these were all considered sort of, if you will, enablers in this kind of context. Very many evidence-based practice tools were mentioned as real support to help with integrating and supporting E-integrated care plans, so clinical practice guidelines, best practice guidelines, order sets, decision support tools, etc. And there are also, vendor-developed library of interdisciplinary care plans that people had mentioned. In the context of integration across providers, it was critical that there be maturity in the context of interprofessional collaboration and coordination. The one key message really taking away is the E-integrated care plans is a tool, is an idea, it's a tool, that there are many other things that need to happen in order for that tool to have meaning and importance and effectiveness. And interprofessional collaboration and coordination is really important, and we really heard that this morning as well. You need those care conferences. It's not just the tool where individually you go in and put your information in. It is the involvement with patients. It is it is really a collaboration. There were other components that people talked about. Having taxonomy of problems and interventions would be helpful to unify goals, interventions and documentation, having standardized language, standard formats and templates, as well as ensuring compatibility with professional standards. Education became is a key enabler. So not only in terms of ensuring that there's alignment in terms of those overlap of scope of practice and so forth, but also in the context of using something like a care plan. How does one work with it? How do you effectively and successfully engage with patients and their significant others and so forth? So education is a key enabler. Accountability, we heard about accountability this morning as well, but there were also some broader issues around legislation and regulatory concerns, especially when there are overlaps in roles and responsibilities. Who's accountable for the full plan of care? Are they accountable for certain interventions? Where does accountability get transferred? How do you avoid duplication, avoid harm? And again, issues of privacy and security that were mentioned earlier. In terms of integration across settings, the kinds of questions that kept coming up that still need to be really resolved are, again, who is the custodian of the information? Who will be the primary coordinator? How is care plan shared, archived, older care plans archived? How does one know when care plan has been updated? And so forth. Lots and lots of discussions around technology, and the key really enabling elements are having it seamless, dynamic, and meaningful. And seamless really in terms of not having the tool tell you what to do, but really have the tool flow and support your clinical work and your clinical pathways and so forth. And the last set of enablers really fell in the context of governance, having a cohesive direction. A lot of people talked about the fact that there are multiple initiatives that are underway in the provinces, and sometimes not knowing how they dovetail, how do they connect. So having some cohesive direction and certainly supports in terms of change management.